Welcome to Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware with Dr. Nicholas Biasotto. Dr. Biasotto is board certified in family medicine, and he has extensive experience and training in treating patients with addiction and substance abuse. Now, let's join Dr. Nick Biasotto for Delaware Healthcare Reality.
Hi, this is Dr. Nick Biasotto, the host of our podcast, the Medical Society of Delaware, Healthcare Reality. And today I have a special guest who's been here before. It's his second time. It's Dr. Rich Henderson. I will get to him in 1 second, but I'd like to do some housekeeping, if I may. Everyone's wondering how to access our podcast. There are multiple platforms that you can reach the podcast and listen to the cast itself. You may listen on Apple. You may listen on Spotify, YouTube, Amazon, TuneIn, Alexa, iHeartRadio, Player FM, Samsung, and Podchaser, as well as Podbean, the Podbean, B-E-A-N app, Delaware Healthcare Reality. But we'd like to know also how you all feel about these podcasts. Are you enjoying them? Do you have any suggestions for future ones? Please let us know. It would be very appreciated. And how do you let us know what your questions and concerns are, or possibly ideas for future podcasts, by getting on that computer and going to healthcare.reality at medsocdel.org. I'll say that again. That's healthcare.reality at medsocdel.org. Again, before we get to Dr. Henderson, I'd like to just bring to the attention of Delawareans this new syndrome that has seemingly developed. It's called the alpha-gal syndrome. Doctors, keep your eyes out for this. It's not caused by an infection, but it's an IgE-mediated allergic conductor after the bite of a lone star tick. What's a lone star tick? Well, it's a lot bigger than a deer tick, and it has a white dot in the middle of its body so that you can recognize it. So after a good feed, the tick can transmit alpha-gal sugar molecules through its saliva. People affected may become allergic to mammalian meat and dairy products. Now, what will they get? Some a rash, some diarrhea, nausea, or vomiting, but there has been reports of anaphylaxis. Also, if you want to test for it, it's the immunoglobulin E antibodies to alpha-gal. That's ALPHA-GAL. Also, there's been a rise in what is being called dengue fever, which has been around for a long time, but usually in the south. Sort of moving its way up. I guess temperature and climate changes may be causing that. And some of this dengue fever is caused. Most of it is caused by a mosquito bite, which can produce nausea, vomiting, muscle pain, arthralgias, joint pain, and rash, which is like red dots. Sometimes it gets life-threatening with severe bleeding and shock. If you need to test for that, that's a virus RNA early in the course of the disease. Ask for dengue virus. And that's it on our housekeeping. Now, again, I would like to take the honor of introducing our guest, Dr. Richard Henderson. I've been through Dr. Henderson's curriculum vitae, or his credentials, in the past, and you may hear them on other podcasts. But in brief, he's a past president of the Medical Society of Delaware. He presently is the chair of our legislative committee, which I believe to be one of the most important committees in our society, and he is also the recipient of a very prestigious Tilton Award for his devotion and dedication to the medical society, his colleagues, as well as his community. Welcome, Dr. Henderson.
Thank you.
All right. The 152nd General Assembly in Dover ended on 6/30/24. There's been no surprise bills brought to the floor. As you know from previous communications, from a previous podcast, most of those bills have been brought to your attention, and they were being debated in Dover at that time. Now that they're on a summer break, a lot of these issues have been addressed and voted on, passed or not passed, and that's what we're going to go off with today. But a very important bill was passed, and that is recognizing Orange Crush as the state cocktail, and that's a very important one. Okay, the Medical Society monitored and worked with some 125 bills that impacted physicians and patients in Delaware. Some of these themes include monitoring health care costs, which are continually skyrocketing skyrocketing and are becoming somewhat unsustainable. We're also going to deal with access to care. We have a paucity of family doctors in the state of Delaware, especially in the southern state, so it's hard for patients to find a primary care doctor. And the way primary care doctors are sort of drying up in our United States and being taken over by possibly nurse practitioners and other subspecialties, we need to do something about this and do something about it quickly. Also, we're going to discuss scope of practice. Now, you may ask, what is scope of practice? Well, the only two organizations that are physicians are the allopathic MDs and the osteopathic DOs. All other doctors may have PhDs, they may have master's degrees, and they cannot and should not be mistaken for physicians. So therefore, there has to be some way that this is advertised in a way that there's truth in advertising and that their scope of practice includes just what they can care for. Fiscal responsibility is another big one that was on the agenda down in Dover, and we need to rein in the costs. And how do we do that? Will be discussed later in this podcast. And the usual insurance mandates, i.e., prior authorizations being a big one. Prior authorizations, as you know, is a problem for doctors as well as patients. I had a podcast earlier on that subject, going over it, panning it basically, because in my opinion, this particular process should be ended. Okay, so let's talk, Dr. Henderson. Talk to me about H-Bill 314, which amends Title 21 and 24 of the Delaware Code related to driver's license.
Thank you, Dr. Biasotto. So HB 314 is a result of work between the Medical Society and the Division of Motor Vehicles and DHSS. Those two organizations came to the Medical Society after reviewing their codes, which are almost 60 years old, and focused on CNS conditions such as seizures or loss of consciousness as indicators for which physicians were required to report to the state, and often led to having someone's license taken away from them. The Medical Society was able to help them understand that there are many other conditions that can cause loss of consciousness besides CNS disorders. And we also voiced concern that the code as written placed physicians in the uncomfortable role as being police officers, where they were having to report their patients to the state, and this often created some relationship difficulties with possibly patients not being as forthcoming about their conditions and leading to some other problems. The state, the DMV, was very receptive in working with us, and the changes that were made in the code are consistent with changes that have been made in 45 other states that also removed the duty to report. I'm happy to report that that was eliminated from House Bill 314. This was a primary focus of Dr. Varapapa, who's our current MSD President, who is also a neurologist and was very, very helpful in helping to get this through. I would also like to add that this is an excellent example of collaboration between the Medical Society and the state agency to address a healthcare-related issue. I hope our legislators were paying attention and will follow that example moving forward.
Thank you. I guess that takes the doctors off the hook somewhat, don't you think?
It does. It doesn't. You still have can report a patient, but you're no longer required to by law. So if you have a patient who you feel is unsafe to drive, you have still every right and a responsibility to do so. It's just no longer mandated.
I've had patients like that where I had to mandate the fact that their license be removed and call the DMV for that reason. I also have some patients who the family says, he shouldn't drive anymore, Doc. Right. Not having seizures, he doesn't have any brain illness, but he can't remember how to get around the block. And he's not driving so safely. So sometimes I simply say, well, go down to DMV and retake the test and see if you pass and let me know. And if they pass you, I guess we're stuck accepting that. And if they don't, well, give your license up. Okay, thank you. All right, how about House Bill 274? This amends the Delaware Code related to insurance coverage of allergen introduction in dietary substances for infants with no charge to the uninsured patients. So go ahead on that.
Yeah, so as you know, food allergies have a significant negative impact on children and their families. This bill is a result of a resolution that came forth from the Medical Society's annual meeting, and it requires health plans to cover allergen introduction for dietary supplements, particularly with peanuts and egg-related products, for infants up to 1 year. This bill was passed and is waiting for the governor's signature at this time.
Okay, thanks. Now we have Senate Bill, I guess, 1 and Senate Bill 2, or for Senate Bill 2, with House Amendments 2, House Amendment 6, House Amendment 10, and House Amendment 11, updating the code relating to deadly weapons. Go ahead with this one.
This bill was also the result of a resolution passed at the Medical Society's annual meeting, which called for legislation highlighting gun violence as being a public health hazard. As you can see from both the Senate substitute bill and a number of House amendments, this was a highly debated bill that focused only on handguns. It creates a permit application process for the purchase of a handgun. It requires training on handgun safety before a permit is granted. It prohibits licensed importers, manufacturers, dealers, and unlicensed persons from selling or transferring a handgun to someone without a handgun purchase permit. The governor has signed this bill.
Now some priority issues have come up to the Medical Society, and obviously, again, we have to hit on the prior authorization bill, which is Senate Bill 110, which updated MSD and DHA, the Hospital Association, collaborated on this particular issue because, as you know, and as I've said, it's very burdensome. The AMA position has lessened some of the burden, saying it will reduce the cost of care over 10 years to physicians and their office staff to the tune of about $15 million, or is it billion? I forget the B or the M. And surrounding state positions such as Kentucky, Arkansas, Illinois, and Georgia, and Pennsylvania were also discussed in trying to lessen the burden of this process. Excuse me, talk to me a little bit about that.
So Senate Bill 10 deals with prior authorization, as you mentioned, and you have gone on the record with regards to the impact that prior authorization has on both patient care and on practices. Senate Bill 10 builds on House Bill 381 that was passed in 2016. That bill put Delaware on the forefront of addressing prior authorization, and one of the key elements of it was it required statistics on appeals, the specialty of the provider, indicators for denials, and the number of denials overturned on appeal be reported to both the Delaware Health Information Network, or DIN, and the Department of Insurance. That has not been enforced as vigorously as it could have, so we have no data, which we hope that statistics would give us, to show that whether prior authorization is indeed benefiting patients the way it is intended, or if it's just another contributing factor to the administrative burden that physicians' offices have to deal with, and also try to understand whether this is truly benefiting patients. So as you mentioned, Senate Bill 10 was a collaborative effort between the Delaware Hospital Association and the Medical Society. It's based on a model that's been used in other states, including Pennsylvania. In Pennsylvania, it took 4 years to get a bill passed with regard to prior authorization. Senate Bill 10 added 3 important elements that were excluded from the bill that was passed in 2016. The first is qualifications of reviewer. This is included in legislation in 24 states and the District of Columbia now. It addressed the peer-to-peer appeal requirements, which is also included in 24 states and the District of Columbia. And third, it prevents retroactive denials, which is also included in legislation in 24 states and the District of Columbia. Senate Bill 10 was heard in the Senate committee in May of 2024. During that hearing, the Medical Society, the Delaware Hospital Association, and the AMA, as well as some other individuals and groups, testified in support of Senate Bill 10. Senate Bill 10 was opposed by Highmark and AHIP, which is a trade association that represents the insurance companies across the country. Senate Bill 10 was not released from committee because of a fiscal note that was associated with it, which both the Delaware Hospital Association and the Medical Society were not aware of until that hearing. We have been talking about prior authorization and working with the Delaware Hospital Association on this for at least a year and a half, and this is the first time that we were made aware that a fiscal note was included. It is our plan to continue to work on prior authorization and work on improving Senate Bill 10, and it will be reintroduced in 2025. Prior authorization is now also on the federal radar with changes that are requirements for many of the Medicaid Advantage plans. So this is something that's also on the national radar. It is not limited to what's happening in the states.
Very good. I think that's a good start. I'd like to take a little break at this time before we come back with the rest of the bills that we need to discuss. We'll be back in a moment.
Information about the Medical Society of Delaware can be found on our website, medicalsocietyofdelaware.org. Questions about our podcast can be emailed to healthcare.reality@medsocdel.org. That's medsocdel.org. Once again, here's Dr. Nick Biasotto.
Okay, we're back with Dr. Rich Henderson, our chairman of the Legislative Committee here at the Medical Society, discussing various bills that have been voted on, denied, approved, or sent to the governor's office for signature. But let's talk about the next one. This is Primary Care Reform Update, Senate Bill 120. I'll make a comment and say that Jim Gill has worked very hard to get this thing across, and the message is always the same, and I'll reiterate the message. Primary care doctors are not reimbursed on a significant basis to keep them alive as a profession. This is my subspecialty, and I'm watching it go away, and I'm watching it being chewed away bit by bit by arms of certain arms of medicine that consider themselves to be physicians, but as you know, they are not. For example, and I will be doing a podcast in the near future on nurse practitioners and physicians and see how that applies. But I'll give you a brief stat on the issue. Nurse practitioners, before they could hang a license, before they can hang a shingle on their door, have to have about 5,600 and so hours of training. A doctor, before he can hang his shingle on the door, is 26,000 or greater hours of training. So who would you want to go to? All right, so let's go. Rich, take it over.
Senate Bill 120 was passed in June of 2021. This bill was signed by the governor in October of that year. It's based on legislation that had been passed in Rhode Island, which was groundbreaking here in Delaware because, as you mentioned, it required the payers to make scheduled increases in reimbursements of primary care practices over a 3-year period. And this was, the impetus for this was, as you mentioned, primary care here in Delaware continues to decrease. Reimbursement is one of the primary issues for being able to keep an office open, being able to employ the people who work in those offices. And the current reimbursement makes that very challenging for our primary care colleagues. So many of them don't leave primary care, but they either go to a concierge model where the panel of their patients may be limited, or they become employed by hospitals, and that doesn't necessarily lead to decrease in healthcare costs. The intent of Senate Bill 120 was blunted considerably by how the regulations were written. That gave the insurance plans the power to determine which practices were involved in practice transformation, and this became one of the requirements for qualifying for those increased reimbursements. The regulations also gave the plans the ability to determine how patients would be attributed to a practice, which also impacted reimbursement rates. We've been working with the sponsor of Senate Bill 120 to address the issues that have made it less effective and look forward to working on this in the next legislative session as well.
Rich, keep up the fight. This is something definitely needed. It's this state as well as other states in the United States. I remember when I was president and met with the Delaware Bar Association, their president and their council, and their president at the time said to me, "Dr. B, why do you consider us your adversary?" And I said, "Well, I'm not sure we consider you an adversary because we all worried about malpractice at that time." He said, "I think you should look at the insurance industry as your adversary." And guess what? He hit the nail right on the head. What you think, Dr. Henderson? What you think on that? True?
There is a definite kernel of...
Okay, let's go down to House Bill 447, Truth in Advertising.
So as you mentioned earlier, there are an increasing number of non-physician clinicians who are obtaining advanced degrees at the doctorate level, which allows them to use the term doctor. The Medical Society feels very strongly that there must be clarity in how this term is used in both the clinical setting and in advertising, as you mentioned. This is consistent with the saying that all physicians are doctors, but not all doctors are physicians. And so it's very important that the patient be aware of the credentials of the person they're seeing and whether that person is a physician or not. The Medical Society has worked with the AMA in crafting bill language. House Bill 447 was introduced by the bill sponsor on June 21st of this year, which was on a Friday, and planned to be introduced in the following week, which would have been the last week of the legislative session. Obviously, this was problematic with the short timing of it. The Medical Society could not support it as written, but appreciated the concept. And through our lobby team, we were able to put it on hold so we could continue to work with the bill sponsor to get it closer to something that we feel would benefit the public. According to the bill sponsor, we are not that far apart, and so we're really looking forward to what happens at the start of the next legislative session, which begins in January.
Now we have Senate Bill 283, Senate Bill 185, all ending up as Senate Bill 319. And a little history. Around 2009, we had a physician in the state that was convicted, and jailed for pedophilia to his pediatric patients. That, in turn, had a big uproar from the Delaware legislature to insist that doctors take courses in the ability to, you see something wrong, to report it, and we also brought it that we had to take extra courses in recognizing pediatric abuse. That was part of our licensure, and we had to do that. And that continues from year to year. This particular sections of bills, or a number of bills, was to educate us on the diagnosis and treatment and care of Alzheimer's disease, which we do get in our in other areas when we go for our CME training to keep up our certification or to keep up our state license. We do get 2 CME hours for this licensure, but what made it good was what, Rich? Tell me what made this acceptable to us. I know we argued about it.
There was quite a bit of a blowback from the physician community about this, and we were able to reach out to the bill sponsor to help him understand how problematic this was. Quite a few of our colleagues did so independently as well. The bill sponsor was very receptive in the comments that we made and the concerns that we voiced, and he agreed to consider 2 things. One was to introduce legislation that would have delayed the implementation until 2027 to allow for further time to work on the bill. This was particularly important because at the time, the Division of Professional Regulation could not definitively provide guidance as to who this legislation should apply to. There are obviously groups of physicians who do not take care of patients in this population that this would have been a significant burden to, in addition to the hassle that you alluded to of adding to what's required for our licensure renewals. the sponsor did introduce a bill that delayed it until 2027. The second change that we suggested he consider is to make this a one-time requirement for licensure renewal. This is significantly different than where in other states, such as Massachusetts, where this is a 6-hour module and is required at every licensure renewal. The bill sponsor were, again, very receptive to our discussions and did change this to make it a one-time requirement for licensure renewal. It is still going to be a 2-hour CME requirement, but we were able to significantly change the direction of the bill so that it did not become significantly more burdensome. And also, I should note that the bill also includes exceptions for physician populations that are not involved with the care of this particular special group of patients.
So that's good that we lessened the burden on us again, and we are still interested in taking care of that population that has Alzheimer's disease. And some new data, I just read the paper today, there's just been a release that some of these GLP-1s that are for weight loss are seeming to have effects on lessening the course of Alzheimer's disease. Interesting, and I'm sure there's much more research needed in that area.
So this is an example of why advocacy by physicians is so important. This bill was introduced in the last week of the previous year and passed in that same week without input or consideration by the medical society. With our lobby team and the response by our colleagues, we were able to have a dialogue with this particular legislature to help him understand, while the intent was good, the execution or the impact that it would have had would not have been as much so. So advocacy by physicians was very important in helping to change the outcome here.
All right, next is Senate Bill 194, increased scope of practice for pharmacists. Where did that end up? I was not sure where that ended up from my review.
This Senate Bill 194 allows pharmacists to initiate, dispense, and administer medications for HIV, post-exposure prophylaxis, and pre-exposure prophylaxis. It was based on the premise of increasing access for this particular population because the legislators felt it was easier for those patients to see their pharmacist as compared to getting an appointment with either their primary care physician or an HIV specialist. The Medical Society supported the increasing availability of post-exposure prophylaxis, but opposed the pre-exposure prophylaxis component because, as it was written, was not consistent with CDC guidelines, and there was concern about what would happen or the lack of follow-up that may occur if an abnormal result was obtained, because this is not something, an area that the pharmacists have particular training or expertise in. Medical Society also voiced concerns about the expansion of increasing access to testing without increasing access to care. The Medical Society was successful in introducing an amendment defining what the pharmacist is required to do if a test result comes back abnormal. This bill was passed with the amendment suggested by the Medical Society and is awaiting the governor's signature as well.
This is a very controversial one, House Bill 350, Hospital Cost Review Board being established. Tell me a little bit about that.
House Bill 350 significantly altered the flow and direction of the legislature when it was introduced this year. It creates the Diamond State Hospital Cost Review Board, which has responsibility to review and approve hospitals' annual budgets and request for rate increases as of 2026. This is in response to the rapidly increasing healthcare costs for the state and previous efforts at bending the cost curve and benchmarking that have not been successful over the previous years. This bill was signed by the governor. I should also say that it exempts rehab hospitals from this review process. The bill was signed by the governor, but is now Christiana Care is now suing the state, challenging the creation of this new regulatory entity. The Medical Society was neutral on this after quite a bit of discussion because of concerns about the possible impact on our employed physician colleagues across the state. As I said, the governor has signed this bill, but Christiana Care is definitely has introduced a suit, so we'll see where it goes.
That was just in the paper today. Christiana Care files suit, but doesn't it also? I thought when we went through all this that in the end we were worried. We did take a neutral position of opposition initially at the board level because we feared for our colleagues in the hospital setting. But then when the general counsel of the society met, they decided to go into a neutral stance. We got to do something about the cost of care. I myself believe that the cost of care in the hospital setting is pretty expensive. And that's driving the cost in Delaware. I think we're in the top 10 at least for the amount we spend on medical conditions per capita. So I'm glad you told me how it ended up because I was not sure where it ended at the end. All right, Senate Bill 13, Protect Medicaid Act of 2024. What's that?
So this was also affectionately known as a provider tax. It creates a health care facility assessment to support state-funded Medicaid programs. The funds generated by this assessment would be matched by federal funds, which would increase Delaware's allotment in the Medicaid category. The Medical Society watched this carefully to make sure that this would not apply to physician practices as well. So at the current time, this is limited to the large healthcare facilities.
Okay, now we have the next bill, which is House Bill 374. This is a good one. It provides legal protections to physicians and clinicians who provide contraceptive and abortion services to their patients, and MSD supports this. I guess that's self-explanatory, is it not?
It is. So this was one of 11 bills that were introduced this session related to women's health care.
Okay.
House Bill 374 updates House Bill 455 from the 151st General Assembly, and it provides legal protections for physicians and clinicians that provide fertility care and treatments from the laws and regulations of other states where this type of care may be illegal. It also protects the communication and records concerning fertility services by requiring patient consent before that information can be disclosed in the event of a civil action generated by another state. So this is, as I said, one of the 11 women's health care related bills that protects both patients and physicians in the area of fertility care, which is very important.
Okay, so one question for you is I don't know the answer. You being an OB/GYN and front edge of this stuff is do we have a time limit for obtaining an abortion in the state of Delaware?
I believe that we do.
And what is that?
When I did my training, it was 20 weeks. I don't know if that's been changed.
Okay. All right. Thank you. Now the next is increasing coverage for added postpartum visits with a doula. That's House Bill 345 with House Bill 362. I guess that's obvious too with what it stated. Anything you want to add to that? House Bill 345 requires Medicaid to cover postpartum visits with a doula based upon a recommendation of a licensed practitioner or clinician. The thinking here is that this may be a way to identify postpartum complications a little bit earlier and contribute to efforts to reduce both maternal and neonatal morbidity and mortality. House Bill 362 is in the same vein of requiring coverage for doula services under the state's Medicaid plan beginning in 2024. House 362 also requires similar coverage by private insurance plans. Okay.
So this covers both Medicaid and the private insurance plans to provide coverage for this particular service.
Let's make sure that's followed and that the insurance industry outside of Medicaid does what they're supposed to do. End of life options passed but not acted on by governor. Is it 10 days after this passed? Did he act on it? Has it become law, or what's the deal on that?
That we haven't heard. House Bill 140 addresses medical aid in dying, which we may have discussed previously, which allows a competent adult who's a Delaware resident with a terminal condition to request and self-administer medications that would end their lives. The Medical Society's position on this has been engaged neutrality, which means that we would serve as an unbiased resource to inform legislative efforts that will support patient and physician shared decision-making while continuing to advocate for improvements in palliative care and ensuring patient protections and safeguards. This bill has been in the works for at least 8 years.
8? Oh, I thought it was less. Okay.
It may have been less than that, but it's been around for a while, and was just passed at the end of this current session. It has not been signed by the governor, but could become law without his signature after a certain period of time passes.
In the 10 days after?
I think that's what our lobby team said, so we're probably pretty close to when that would come into effect.
Got it. I know that we are in what was it, engaged
neutrality right.
To continue discussions on that issue. I know that our president, Dr. Vera Papa, was very strong proponent of that, and it finally got through.
And importantly, on this issue, there was an editorial in the News Journal in early July that inaccurately stated that the Medical Society would be training physicians to participate in the medical aid in dying process. That is unequivocally incorrect. The Medical Society's position will not be training physicians to participate in this process, but as I mentioned earlier, to serve as a resource for discussion as this process moves forward. So for the record, the Medical Society is not going to be training physicians to participate in this process.
I agree. All right, lastly, before we end it, House Bill 253, the update on the Delaware Code relating to mammograms.
House Bill 253 is another one of the efforts to increase access to testing without necessarily increasing access to care. It requires health plans, including the state employee and retirement plans and Medicaid, to cover annual mammograms for women who are 40 years of age and older, with or without, and that's the most important part, without a referral from a clinician. It prohibits facilities from requiring the woman to provide the name of a healthcare provider to have the mammogram done. As I said, this is another example of increasing access to testing without increasing access to care, particularly with regards to results that may be abnormal. The Medical Society voiced concerns about patient harm that may follow because of this inability to identify who this report would go to and who the patient would then turn to for questions that she or her family may have.
Or for guidance.
Or for guidance about what the next steps are. So again, another bill where increasing access is a good thing, but without the infrastructure in place or paying attention to the need for the follow-up is absent, and so that was a problem for the Medical Society.
And it passed, though?
I believe it did.
And there's no provision to allow for the physician that the patient sees to get a copy of that mammogram?
Oh, no, the patient has a right to get a copy of the mammogram.
But how about the doctor that's her primary care? Or
if she does, if she chooses to identify that particular person, she may do so. But the current setup is that the patient has to be referred for the mammogram, and that study report then goes to her referring physician or clinician. This will allow patients to access the mammograms without having a referral, which is not necessarily a bad thing. But the follow-up for any abnormal results is where the things get lost in translation and could present a problem for patients who do not have a primary care physician.
Gotcha. Are there any bills that I failed to list here that you want to go through?
No, we've covered quite a bit.
I think we did a good bit at a time, too.
As I mentioned earlier, this was a very active legislative session. I don't recall in the years that I've been on the Government Affairs Committee where this number of healthcare-related bills have been discussed. As I mentioned earlier, 20% of all the bills that were introduced this year had to do with healthcare. Our hope in continuing to work on establishing a relationship with our legislators is that they will consider us as a resource to come to before legislation is introduced for input so that we may have an opportunity to improve the legislation or so that it doesn't put the medical society in a position of appearing to be reactive, which it currently is, because as things went this session, there were quite a few bills that were introduced without medical society input, and when we did find out about them, our response appeared to be reactionary, which to both our members and the patients is not a position that we would like to be in.
Well, I'd certainly like to congratulate you on running an excellent committee. I think you're a good man for the position. You know how to get the points across. You lead your committee in the way they need to be led. For those listening to these podcasts on legislative issues, podcast number 6 you just heard. Podcast number 5 was basically a tee up to 6, so you can see how the process works. As I mentioned earlier, the podcast with Dr. Henderson and Kim Gomes, our lobbyist, is a tee up to this one and see how the bills have passed from being discussed to being approved or denied, etc. Well, that's the end of our 6th podcast. I hope you enjoy it. Remember, you can give us the information, or you have any questions, or you have any concerns, or you want to add information for future podcasts, please get to your computer and type in healthcare.reality@medsocdel.org. And this is Dr. Biasotto saying thanks for listening. See you next time.
This has been Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware. For more information about MSD, visit our website, medicalsocietyofdelaware.org. For questions or suggestions regarding our podcast, email us at healthcare.reality@medsocdel.org. Thanks to audionautics.com for our music. Delaware Healthcare Reality is produced by Tom Mitton. I'm Lori Ann Rhodes. Watch for our next podcast episode. Until then, be well. The Medical Society of Delaware, MSD, is providing this podcast for informational purposes only. It provides neither medical, legal, nor any other professional advice. The views, thoughts, and opinions expressed by the hosts or any guests are their own and do not reflect the views or policies of MSD. Unless specifically stated, reference to any specific product, service, or entity does not constitute an endorsement or recommendation by MSD. Reliance on the information provided in this podcast is exclusively at the risk of the listener. MSD expressly disclaims any and all liability or responsibility for any direct, indirect, incidental, or other damages arising out of any individual's use of, reference to, or reliance on this podcast or the information presented in this podcast.